This is Anna Scanlan here of the IED Hub, and I'm very pleased to have with me here today different members who have a shared interest in improving digital health literacy. And although they're working in slightly different disciplines, this interest has overlapped to bring them here today. So I think I'll let you all introduce yourself.
Thank you so much. My name is Laura Sahm, and I'm Professor of Clinical Pharmacy. And I have an avid research interest and a passion about health literacy because I've seen how it can affect patient outcomes in, day-to-day settings. So thank you.
My name is Dr. Tamara Vagg, and I'm a research fellow. I specialise in digital health, but I work as an embedded research fellow in the Cork University Hospital with the Adult Cystic Fibrosis Unit. And I recently came into digital health literacy because we found that this is really important towards implementation and sustaining digital health solutions.
My name is Dr. Sarah Robinson, and I'm a lecturer in the School of Applied Psychology, and I work with the People and Technology Group. So we have a broad interest in how people engage with, interact, and are influenced by technology. And I have a particular interest in responsibility, so how we can be responsible citizens in a digital era and what information we need to do that. So my interest in health literacy is emergent based on that work. And I guess I have a personal interest in health literacy as someone who lives with a chronic health condition and how health literacy has supported me in my ongoing journey to be as well as I can be.
That's really interesting to hear, actually, because I had a chronic health condition as well for many, many years. And I think the ability to use online interactive media and just simply to be able to use a PowerPoint and emails actually allowed me to get my degree. Digital health literacy, that's not a phrase that's going to be that common to everyone. So first of all, what is health literacy?
Yeah, so health literacy is the cognitive and the social skills which determine our motivation and ability to gain access and to understand and use information in ways that promote and maintain good health. And that's taken from the World Health Organization. So when we talk about that, we can also think about what it means for the person. And that would be the degree to which individuals have the ability to find, as you've quite eloquently said, to understand and to use information and services to inform health-related decisions and actions for themselves and for others in their care. And then we can have, I suppose, if you think of a bottom up being the person, and then a top down would be the organizational health literacy. And that's the degree to which organizations, say, for example, the HSE, equitably enable individuals to find, understand, and use information to inform these health-related decisions so that people can make decisions that can positively affect their outcomes. Thank you.
Very, very good. And Tamara, have you a kind of an understanding of it as something else, or is that it in a nutshell?
I think that would be it in a nutshell. In fairness, no one can say it better than Laura. But where I come into it is like where this world meets the digital competency world, which, to be fair, I think is where Sarah has the most expertise, is on the digital competency side.
Thank you, Tamara. I'm not sure about that. But I guess in terms of digital competency and maybe where it overlaps with health literacy, I'm, I guess, interested in an EU framework called DigComp, which is a digital competency framework specifically for EU citizens. And it defines digital competence as involving the confident, critical, and responsible use of and engagement with digital technologies for learning at work and for participation in society. And they define digital competence as a combination of knowledge, skills, so very tangible skills, and attitudes. And I guess across those competencies, they define them into 5 core areas. So one is about information and data literacy. And I think in that we can see a really big overlap with health literacy in terms of people being able to articulate their information needs, so their health information needs, to locate and retrieve relevant digital data and information and content. And I think critically also to be able to evaluate that information and content. And as we saw during the pandemic, with the infodemic, that skill to evaluate information became critically important. But they also talk about the importance of communication and collaboration. So that some of the points you were making about being chronically ill and being able to avail of the infrastructure that the digital world provides us to participate in society and in your work and in your life. It also talks about digital content creation, safety, which again becomes really important when we consider health literacy. So they talk about safety as more than, but very linked to things like cybersecurity and the protection of our data in a health context. But also protecting our own physical and psychological health and well-being when we are online and when we are using these resources and tools. They talk about the knowledge and skills and attitudes that we need to be able to do that. And also, really interestingly to me and in my current work, is they talk about the importance of environmental safety, which obviously links up in an era of climate change with some of the social determinants of health. And they talk about our ability as EU citizens to kind of understand the environmental impact of our engagement with digital tools and technologies. And then lastly, they talk about problem solving. So being able to identify needs and problems related to our interaction with the digital world and digital environments, and to use tools to kind of innovate processes and products. And within that, you could think about maybe innovation of health services to people.
And I suppose you have to have a certain level of skill before you get online and start using all of that first. And I know everyone takes for granted that everyone can do this because everyone has mobile phones now. Everyone can WhatsApp, everyone can go on different things. Therefore, you must be able to send emails or you must be able to set passwords. And it's actually a big problem.
Absolutely. Yeah, that's I think some of the assumptions we have in this space. So what you're describing there is something that I often see in research, which I hate seeing, which is digital natives. So we have these generations of individuals who've grown up with technology. And by proxy, there's the assumption that because they've grown up with the technology, well, then they're quite skilled in using it. And I think over my course of speaking to a few individuals in UCC about digital literacy specifically, before we got to the health literacy space, often lecturers are finding that that's not the case. So yes, they maybe can use their smartphone quite well, but then there's all these competencies linked with it, like safety. And then we have these new things coming in here like digital well-being, digital fatigue. So how do you stay well online and not get too tired or inertia from using all this digital technology? So that's an assumption we have, which we have to try and work around. And then we also have something on the other side of that, which is called the grey divide. So there's this big presumption from a digital health perspective that older adults, so they're usually classes like 64 and above, some will go 60 and above, they don't have access to the technology, nor do they want to learn. So by proxy, we won't include them in this digital health implementation. When in fact, actually, when you get into the nuts and bolts of it, they do have access to the technology, they do have a willingness, and they also have a time to spend it learning. It's actually who's going to learn them and who's going to give them those skills.
Who'll give them the time. And I mean, just even myself, say I had kind of recent experience. I ran a study a couple of years back, and these were with students that were in second year of their undergrad. So I assumed there would be no bother sending them a lesson by email, that they would download this lesson, follow the instructions and take part in the study. And the first time I did it, there was big feedback. I had technical difficulties. I couldn't see your lesson. I couldn't open it. And all it was I had put a PowerPoint lesson as an attachment and they hadn't actually downloaded it. Okay. And unless they downloaded the PowerPoint, they couldn't actually interact with the lesson.
Yes.
Yeah. Making such a simple change, they saw that as a technical problem I did myself to begin with, until I spoke to a few of them and got to the bottom of it. All that had to change was a simple instruction in the start slide that when they would open the email, the first thing that they would see is, you must download this PowerPoint. And all technical difficulties disappeared overnight. So it is a big assumption, this whole thing, digital natives. It doesn't mean they've ever been introduced to editing in PDFs or simple things like that.
Absolutely. Yeah, and then there's the learning it correctly. A lot of people learn workaround solutions to get a job done. It doesn't mean they've learned it correctly. Like what you said there with your students, they're maybe used to opening things embedded in an email. That might not be the best way about handling that. So there's a lot of things within that digital competency. And then phobia, you mentioned a bit there about your students coming to you in kind of a panic saying it's not working. And then yourself, you were like, oh no, maybe I've done something wrong. But in truth, this is what happens when technology fails. We panic and we tend to think it's either a big technical issue or it's ourselves that have caused it, when in fact it's probably, like you said, just an instruction needs to be added. But the more the phobia builds, the more the skepticism builds. And then in the digital health space, we pull back from trying to use these things, or we're less likely to buy in. And that's the problems around phobias and confidence within the space also.
Do you know, that's a great point actually as well, because I suppose they're tools of communication, yet we communicate poorly how to use them.
It's very important. Also, you referenced the older adult and, maybe the great divide. And when I think about that in terms of the health continuum, I mean, what we're seeing certainly as a demographic in this country is that we're having more and more older people. And that's a success story, But the difficulty is that it tends to be that the older you get, the more unwell, or you can have more morbidity or more sicknesses and more medications. And I suppose the irony is that with the new health system, the health digital systems that the HSE and others are coming out with, you may have all of your health information at the touch of a button, which it can sound so empowering. I have all this information, but I think to your point, it's important to realize that not everybody has the skills, ability, nor do they necessarily have it. They need to have it to interpret it. And how can we accompany them on this journey to help them critically evaluate it, say, I'm always reminded of the words that we use in the medical field or, pharmacy field. We can use terms like saying something like, well, how was my test? Oh, your blood tests were unremarkable. You'd be a bit disappointed, really, wouldn't you? Yeah. Really, I thought they were quite good. And that's a good thing to say that they're unremarkable, or saying something, oh, you've got a negative test. I mean, I think we probably know after COVID that that's a good thing, but generally using the word negative tends to be negative. And I had a particularly, I suppose, poignant moment when a colleague was telling me that he works in an oncology clinic and that he was almost nervous to meet this patient because he knew that his cancer had moved from stage 3 to stage 4. But when he met the patient was in wonderful form. And for my colleague, there was a kind of a disconnect between like, why is he in great form? So he said, oh, and how are you doing today? And the patient readily smiled and said, great, my cancer has progressed. And he said, okay. And what do you think that means? And he said, well, it's getting better. It's progressing. Oh, no. And those are words that we, in our field maybe take for granted that it's very clear what that means. But obviously it wasn't. And then he had to turn around and translate this. Yeah. And the subsequent, I would think, horror and fear and upset and everything, that's all. Yeah. So I think it's anecdotes like that make me want to tell fellow health and care and social care professionals that how we communicate is really important, and that also for patients that, we're there to support them on their journey to find the information that they need to make decisions about their care.
That's so true, because even say your prescription, your medication, and I know you've a big interest in that, but for your standard packet of paracetamol even, it would frighten the life out of you to read the potential side effects and everything else,
Right.
And I suppose that kind of fear also fed into the COVID-19 misinformation and everything that went with that. And that comes down to language as well. It comes down to not understanding the language of science and the language of medicine. And often those leaflets, they could be 5 or 6 pages long. They're folded up. They're so off-putting. We're asking people to go from that to like online versions and engaging with online tools. There is a fear there and just a lack of interest there. Why would you?
Well, I think to your point, we've done some research on patient information leaflets, their readability, their actionability. In other words, how would I proceed with this drug if this is the information I'm given? And what we find is, and the research would back this up, that actually these patient information leaflets are not checked by patients. They're not pilot tested by patients. These are about insurance. These are about the manufacturer of the product. These are about, health product regulatory authorities making sure that everything that needs to be said is said. There isn't an awful lot of emphasis on, well, is the language accessible? Is the language simple? Is this, what do I really need to know? And it's funny, we're looking at some research at the moment on patients with aphasia, which is a communication disorder that many people who've suffered a stroke may have, and looking at how we could make the information on their patient leaflets more accessible. And they've come up with amazing suggestions. So, if you ask the patient, you will find that they do know an awful lot about how they'd like to be communicated with. What is the salient? What is the most crucial piece of information? And again, to your point, sometimes when you take out these leaflets,
I mean, I'd say people just want to throw them away.
They do. Yeah, I've done that. Yeah.
I always think of the terms and conditions on any sort of software.
Yeah, you just
Read
take it.
that.
You just take it.
Yeah,
You know,
I'm
it's
sure I've
only-
given away my house at some point.
Yeah, I've taken antibiotics in the past, and say if I had an adverse effect to them, then I might run back to the leaflet
Okay,
and look it
and
up.
check, is that
Do you know,
actually
but
an
it's
adverse
too late.
effect?
Yeah,
Yeah.
it's too late at that stage. I mean, I'm thinking of elderly relatives of mine as well who get their tablets blister packed and everything.
Right.
And who are lucky enough to have a son or a daughter go with them to the doctor
Yeah.
to take all the information on board about their condition. It's kind of handing it over to someone else completely because it's just bamboozling. I suppose education has progressed fantastically in Ireland, but I have relatives that left school at 12 and
Yes.
went working.
Yes.
You know, and that was the end of their formal academic education. In life, very successful, very socially wise, everything else. But
They
that's
might
all
not have
taken
had
for
the
granted.
privilege of,
A higher. And I say that to our fertility students the whole time. You don't know how lucky you are that you're one of the, the very privileged few who can go to a higher education institution, who has this ability, but then comes with that a responsibility to help your patients, to deconstruct this information to them and do it in a kind way. Because we have come across lived experience advocates who have coped very successfully with relatively little education. And I say to my students, these are not stupid people. These are people that did not have an opportunity. And in fact, they're probably 2 steps ahead of you at every step because they're trying to compensate. They're trying to anticipate. One of our colleagues in the National Adult Literacy Agency shared with us that a way in which he coped was he used to work in the equivalent of a builder providers. And so his job was to fill out the docket. When you'd go there, you'd say, I want this, this, and this. You'd pay, and then you'd go to the docket to the warehouse. And he was the warehouse person. And he said he'd see the guy come in with the docket. He knew he couldn't read. So he'd go up to the ladder. He'd go up to the top rung of the ladder and he'd shout down and say, what do you need? So he was getting the other person to read it for him. Yeah. And I've had instances like that in pharmacy where you would say to somebody, and how many do you take a day? And they'd look at it and they say, well, I take 3 of those a day. And I'd say, how do you know it's 3? And on deeper discussion, there were 3 rubber bands around it. That's how they knew. So people do have coping strategies. But what I want people to understand is, to go to a universal precautions approach, to say, assume, and research would back this up, assume that 1 in 2 people that you encounter will have difficulty around health literacy. Assume that and go from there. And it's not about dumbing information down. It's just about being clear, transparent, and simple in your language.
Yeah, and I mean, simplifying something isn't taking away from the depth of it.
No,
I mean, it's
not
just
at all.
simplifying. And actually, I'd like to bring you in, Sarah, because I know that you have experience communicating across cultures as well. And I mean, that's another level of communication to overcome as well. Have you any particular insights there?
I think exactly the same principles that Laura applies. So I've worked in humanitarian contexts in East Africa and Somalia and Kenya and Ethiopia. And a lot of the communities that we would have worked with there, I worked with UN agencies and with Concern in Somalia, would have been illiterate. So not even talking about digital literacy, but talking about basic numeracy or literacy skills. And what you find in contexts like Somalia is it's a really visual culture. So when you go through downtown Mogadishu, every shop has a mural on it that kind of supports people to understand exactly what service they can get in that context. And it's very similar in so when I worked for Concern, we didn't have a health program, but we had a really large nutrition program. And in those nutrition centres, there would be a lot of visual aids to communicate to families who maybe experience malnutrition or their children might be experienced it, to explain the processes and the treatments that would be provided to them. So I think literacy, the basic concept of literacy and what we know about communicating in accessible and simple ways and understanding the life world of the people that we're trying to impart knowledge to. The medium changes, but those kind of core principles, I think, stay the same. And I think literacy, when I think about digital literacy, during the First World War, most people outside of urban centres in Europe couldn't read or write very well. And I think we understood as a society at that point that we needed massive literacy interventions to check power, to being able to participate in society and to say things like that war is not what we want.
Yes.
And I think as the digital transformation of society happens, we're still living in a globe where 3 billion people have never used the internet. And even within the UK, it's millions of people. I actually don't have the stats in front of me for Ireland, but we're still talking about a lot of people that maybe don't understand the world that for maybe you and I are part of our everyday world. So as we design these services, it's critical that we're not leaving those people behind and that we're bringing them along with us. One of the things in the work that I've done actually on the West Cork Islands, where I first encountered a roadcaster, which to the listeners is what's recording us today. We were supporting the West Cork Islands to have a community radio platform. We didn't realise at the time, because it was pre-COVID, how important those radio platforms would be during COVID, so during a pandemic time, for things like school assembly. So in parts of West Cork, internet access, certainly at that time, hopefully it's improved in that couple of years, but didn't have great internet access. So for students who were isolated at home trying to participate in school, the online world where we all just automatically navigated to wasn't accessible to them. So the community radio was used for school assembly to kind of gather people together and to use the FM, which was an older technology that a lot of people in the hinterlands could access. So I guess the point is that as we innovate health technologies, we actually have all of these older technologies as well that might actually be as accessible. I'd love to see moving forward that some of the innovation happens with those existing infrastructures that we have. And then your question about literacy, I think across cultures, across generations, across all of the different divides that we have as human beings, I think the common denominator is simple, accessible in the modalities that matter for the people that you're engaging with.
Yeah, and I mean, that's speaking very much as well to sustainability. So if something is going to be used effectively and engaged with long term, it should encompass the old skills with the old software and the opportunities for knowledge sharing there. Tamara, you're the tech genius from everything I've read about you.
Yes, you are.
You have a very deep history of engaging with a lot of interactive media, from basic to more advanced, the VR and everything. And I suppose if I was to come to you and just say, what is digital health literacy versus not having digital literacy? So how do I know that I'm digitally literate? Is there like a standard or something that you use?
That's an excellent question. And that's something that everyone's trying to answer right now. So I think you've got the nail on the head there. So the first thing to say is just within the digital health space, definitions and terms are very difficult because they're very contextual. So once you have a term, over time it changes. And I always love to use the example of telehealth. People use telehealth interchangeably with telemedicine. But now, especially during COVID, we use things like remote, virtual. These words have emerged. So it's just very difficult. And in this space here now, where we have health literacy, which I'd like to say is a very defined and very foundational, important thing. And then we have digital competency, which if you look at the research, for the longest time, everyone was aware that this is really important. They use digital competency interchangeably with digital literacy, but they tend to keep it a little separate. So they say this is for your engagement with society, which, don't get me wrong, health literacy is still part of. Digital health literacy is trying to marry those two worlds together now. And again, it's tricky because if you look at the research and everyone at the moment right now where they're trying to figure out what is the definition, what is the evaluation method, how do we screen ourselves or the people we care for to see if they can use the technologies we're bringing out, which is a really big question because the HSE are currently going through a digital transformation and they have their digital framework, which they just released, which is going to be 2024 to 2030. So this will be coming to Ireland and that's really important. But how do we check that not only the people we care for, but the people working within the HSE have this sort of literacy? And that's still a place that's being shaped. So there is a framework or a model that exists called the e-health literacy, and that was published in 2006 by two authors, Norman and Skinner. And more recently, people are they're reimagining it and they're calling it the digital health literacy framework. But really, if you look at it, it's a little outdated. It's still fantastic. It is a fantastic framework because at the time, this didn't exist. They came and they carved out a space for this and they gave it shape. But now we're in 2024 and maybe some of the things that was considered then is not so appropriate. Those authors did move on and they created a survey as well, like to act as a screening tool called eHeals. I say that's probably the more common one that's used actually.
Very often used.
Yeah. And if you look at those questions now, I often wonder how appropriate they still are. So some of the questions are like your confidence with using a mouse. And you'd have to wonder how many people are using mouse, or they've gone to touchscreen technology. And at the time, that wasn't considered an eHeals. Now people do modify and they try to, kind of update it, but it's still, there's some things not missing them, quite hitting the mark. And really what I think needs to be done and what I'm currently evaluating is health literacy meeting the DigiCom framework and put them together.
I agree.
And there has been some excellent researchers out there who have tried to do the same thing, where they've been mapping it and creating these survey tools for exactly that purpose, a very practical implementation science idea, like let's give this to the people we care for, let's give this to our healthcare teams and let's see where they are and how we can plug the gaps. And a lot of the research has come from, say, like the Philippines or Thailand, and they do fantastic things in their native languages, and then they, I imagine, use some sort of AI tool to translate it. And then what we get in English, the literacy of the questions, I don't think the reading level is not going to be understood by the general public.
No.
So we've missed illiteracy.
That's it. Culture eats
strategy for breakfast, doesn't it? I mean, it's you can't really move those two. But I think to your point about the eHeals, that all of these things on the, at a population level, it's really important to measure, because we want to know what we need to at this population level do as a major intervention. But as a human level, people don't necessarily want to be asked, I need to measure your health literacy, So we have to think about other strategies to help people on the ground. And also, as you were saying, Tamara, people who complete these surveys are already people who are able to complete a survey.
Yeah.
So you're only ever going to get a minimum, this is going to be the lower limit.
So that's kind of biased by nature then, without wanting to be.
Of course.
And that feeds into the digital divide then as well, doesn't it?
It does.
That's the big thing there. So we're not trying to, but accidentally excluding individuals. So if our eHeals survey is a digital survey,
correct,
we're only going to get people who can actually access surveys and not the people who need to access it on paper. So none of this is done on purpose either. These are just considerations, and hindsight's always 2020. So these are learned things. And then also I mentioned the term digital transformation, and that's something I just like to highlight because it's a bit of a buzzword. Lots of people use it, and something and when we think of the term digital transformation, it's digitizing a process. But realistically, if you look at digital transformation, it's strategy over technology. So if your strategy is already flawed, if you have a process that has flaws within it, if you throw technology into the mix, all you're doing is magnifying those problems. But unfortunately, the skepticism, the phobias, it turns towards the technology and not the strategy. And that's always something that we have to be aware of for digital health literacy, because there's many very smart individuals, caring individuals out there that look at different circumstances and situations and say, actually, an app could be quite good here. I'll develop an animation to try communicate
that's what the world needs, another app.
Yeah.
An app for Christmas.
But they say this even we spoke a little there about communication styles and often when you said multimodal, because of my multimedia background, but also I have a visual communications background, I immediately think, we go animations, interactive, that kind of thing. But again, you're excluding individuals. It's.
And back to the phrase telehealth. By tele, you're saying television, there's a screen involved. And you'll have people saying, well, does that include mobile phones and all of that? So even just breaking down the terminology, there's so much around it. And I was very lucky to get to go to the MedTech Forum that was here in Ireland last year. I didn't get there this year, but you had a lot of very clever, innovative and enthusiastic people in one place discussing telehealth and digital literacy and where it's going to go. And it kind of struck home, this is majorly important that we get it right. Number one, that if you are getting people to engage more with anything online, you have all that area around GDPR about safety online. So you're giving very, very personal information about health conditions, and you're trusting that the person who is managing this on your behalf is going to treat your data responsibly, ethically. But at the same time, I heard one person saying, well, you have to remove privacy in order for, say, doctors, for example, to get on board to be able to access all of their patients' information. Right. So it's not clear how that's going to go.
It's not clear. And can I ask you, do they have patients, members of the public, feeding into this as stakeholders? Because I'm always conscious when there are great ideas and, you know, they happen in a vacuum where, you know, the end user is maybe literally that. Told about it afterwards.
Yeah, I recall a lady standing up and speaking, but I can't remember what she spoke on. I don't know if it was breast cancer or what, but she spoke about the difference technology had made to her. And they also gave the example of an island off of Clare where they had started using kind of online meetings.
Clare Island.
Clare Island, yes, that was it. Yeah, you might know more about that actually.
I just know that they have been piloting a telehealth programme on Clare Island, and I think they've been getting successful results. I think the thing with the islands is that unless there is a health presence on an island, you are very isolated from health services. So something like telehealth can kind of bridge that gap.
And
can I say a bit on telehealth actually?
Oh,
Sorry,
yeah,
this is a bit of a I'm
Is
big
there a
into
rant coming?
Bit of a rant, just a little one. So I'm the coordinator of a European telehealth group for cystic fibrosis, and we have partners in Australia and America, Canada as well. And what's really interesting when we talk about telehealth, first of all, is that definition. It means different things, but it's also very contextual. And I keep saying this in digital health, it's all very contextual because you have to look at the problem people are faced with. The reason why telehealth has come up as the solution, the infrastructure they have to try implement it, and it's so different. But it's fascinating. I always refer Australia as kind of the big brother or godfather of telehealth, in honesty, because if you look at their telehealth service, they have government-led documents, they have national care models around how to use telehealth, best
and is that
practices.
because of the spread out of the population?
It's because of the geographical dispersion, yes. And they have all these lovely little neat solutions as well. Like, you know, maybe there is part of your clinic visit that requires some sort of physical assessment.
Okay.
So what they might have, they have these telehealth hubs.
Right.
So they would be like a room for assessment in a pharmacy. So you go 20 minutes up the road to your local pharmacy and they can do something and you carry on your visit there. For those who are digitally excluded, then if you don't have access to the Wi-Fi or the technology, or if you're just not comfortable, you can go to this hub and the pharmacist will turn it on for you and you get to use all those services. So they're always fantastic in that. And then you look into other areas. Like I've spoken to many incredible individuals that are really trying to call out for telehealth services across Europe. And there's some services like within cystic fibrosis, so it's a chronic condition, it's lifelong, and you move from, at some stage of your life, depending on the regulations in the country, you move from pediatric care to adult care. In some countries, we don't have an adult care facility.
Oh, great.
Yeah.
So where do I go then?
Yeah.
Exactly. And now we have people aging with CF thanks to all these fantastic medications. So the population of adults is rising. Yes. So how do we do it? And it's really interesting as well, the shape of countries. Sweden is a long country, Germany's kind of quite square. And Sweden, I think they often say that is the pediatric countries our centres are all along the top and the adults are at the bottom. Oh. So it's quite a distance to drive. And in Germany, I think there's two... Kirsten Schwartz, don't kill me if I get this wrong, but there's two adult centres and I think short of 100 paediatrics. So you could be attending. So now telehealth is really important. But then if we think about those countries and infrastructure, it's possible they have time, they have dedicated services, they have IT support, they have dedicated telehealth departments. Some places have their patient association step in and go, okay, we can maybe do small budgets to help with equipment. Or for like if you want to do telephysio, we might be able to help you with a treadmill or something. So it's all very contextual. But then you have centres where it's just like, I just need to get access to a phone. I just need to call that patient 2 times a week and make sure that they're okay and get some sort of...
So it can go from the very basic to the...
Yeah. And like in Sweden, they have AI as part of their telehealth service. So it's in there analysing the data. And in the UK, they're doing tremendous stuff on that. But something you said earlier about health literacy, about interpreting the data.
Yeah.
In Sweden, they identified straight away, like, I'm showing you these graphs, which are your lung function and these other clinical parameters. And this was in a pediatric context, so the parents were maybe panicking. Like, what does that mean for my child?
What does it mean for my child?
So they spent a long time developing that sits on top. So they can get the clinical stuff they need, but they can get something that's more interpretable and meaningful for them. And then it comes back to the visual communications piece and like, can you use colour here to signify something rather than words? So if you put a reading into your phone and the phone goes green, all good. Also, that was my telehealth rant. Sorry about that. It's going to be my own TED talk there. Sorry about that.
I just, as you were talking, Tamara, I always love listening to Tamara. But I was thinking about a researcher that we actually had speak to us in the People and Technology group in UCC a number of months ago. And she was an Ethiopian researcher. And she was using mobile health interventions, I guess, to support people living with HIV and AIDS in Ethiopia. And what her research found is that because HIV and AIDS, there's so much stigma around it, that using mobile phones, well, the stigma combined with poverty. So people were sharing mobile phones. And so the intervention hadn't kind of initially considered that. And the impact that it was having on these particular communities. So context is everything, isn't it?
Yeah, so
absolutely.
Yeah.
I don't know, there's a lot to kind of take on board there. I suppose I like the idea of having, say, the likes of graphs used to explain things, or more visuals, or to have media, even kind of animations to break down for a patient what a virus might look like, or a bacteria, and this is how it infects, and this is how you take care of it, this is how the particular medicine we're going to give you is going to tackle it. I think I'm all for that. I worry a little bit about the development of avatars. I think the WHO kind of reckons that we're going to be severely lacking in health professionals come 2030, so that we need to start looking at the development of avatars and stuff to help mitigate a loss of medical care and stuff. But I worry on that side of it when I hear all things telehealth. I worry that it's going to be like, do you know those support chats that you see online on various websites? I can't stand them, and it's a little.
Want to talk to a person.
Yeah, an AI robot. But that's just it. You've hit the nail on the head. It's down to the personal touch. Yeah. It's the personal feedback, and also like if you were to consider. So we had a child we used to have to take to Temple Street when he was young, and we live on the borders with Cork, so we could be given a 9:30 appointment to be in Dublin. So travelling off up with him, and maybe inside, maybe waiting an hour for your appointment, and then spending maybe 15 minutes with the doctor and all the way home again. So it was very expensive. It was very tiring. And my husband
stressful as a parent,
very
stressful, child.
Very stressful, yeah. And my husband was self-employed. I was at home with the lads. I wasn't in the best of health myself. So sometimes it was just grueling, do you know? And thanks be to God, he had nothing really wrong with him as such. They never got to the bottom of it, but he had kind of resolved itself as the years went on. But we often said, could this not have been a phone call? And we were told no, that he needed to see the child himself, because I suppose you do have the situation where a little bit of abuse could arise, whether it's elderly abuse or child, where, you know, someone could be hidden away.
Yes, that's true.
You know, so it's there's so much to consider when you are like great to adopt the technology. And I know that's the worst case scenario.
I know.
But I suppose you have to consider everything.
It does have,
to an extent.
Yeah, and like that's where, like, again, technology gives us so many potentials, but you have to consider everything. But in that kind of area, like there's this paper, it's called "In the South, If You Give Us Lemons, We'll Make Lemonade." It's actually about telehealth, and it's about telehealth in a CF context. And it's just a letter to an editor. It's very simple. But they had this point on it, which I thought was really good, which was all of their patients obviously had to go to telehealth services because of COVID. And what they found is they got to see into the patient's home. So they got to see how the medication was being stored, but then they also got to see the individuals that had broken windows in the house. So maybe colder and maybe causing a bit more infections. And so there was a little bit more understanding of that picture. And then outside of cystic fibrosis, there's some great initiatives happening in Germany and the UK around social work and telehealth. So there was this paper from Italy, actually, where they were talking about like they have a very rigorous process they have to follow. Like if A is ticked, then you do an in-person visit. If not, then it's a phone call.
Right.
Whereas there we're trying to petition, could that phone call be moved to telehealth, so we still get to assess the environment, the individuals, and especially for things like disability needs.
Of course.
because trying to say on the phone, well, actually the step is too high or I can't get up the stairs isn't the same as actually saying, could you turn the phone on, let me look at it? Actually,
Yeah, exactly.
so it doesn't have to be crazy technology. It could be a WhatsApp call, but it would just made the difference between people falling through the cracks or going unseen to actually having their environment a bit more understood. But again, that goes with the assumption that the people working in social care or healthcare professionals can do that.
Yeah.
As in they have the skills.
Yeah.
And that the individuals can reciprocate that. They have the skills as well. And just like anecdotally, like because I work in the CUH, I observe many healthcare professionals and the level of skills that's there. And it is diverse. It is very diverse. I was only saying recently about an individual where I saw him look at an Excel sheet, write down the results, and then open up Word and type them back in. And that individual was less than 30.
Yeah.
So again, he's our digital native that we presume has the technical skills. Again, we have to think about these skills, these literacies across the board. And something, Laura, you taught me, which I keep having in my brain, is the idea of the continuum.
Yeah.
So you only give as much information as the individual wants to receive. Maybe you could explain that a bit better.
Yeah, I think the point is that each individual is at a certain stage. So, for example, if I'm a mother and I go to the pharmacist and I want to buy pain medication because my child has fever, I want a certain amount of information. And I might be a very active, participant in the sense. Now, I think all mothers and all parents are active participants, but I'm just saying I might say, okay, well, can you tell me, well, like, what are the side effects of this? Or what? So I might want a lot of information, or I might just say, look, how long can I give this for or whatever? So, I mean, obviously, as a pharmacist, we're trained to give as much information as the person needs to safely administer the medication. But at the same time, realizing where on that continuum somebody is and not flooding them with extraneous information. 1 in 10,000 people might have this. Great. How relevant is that to you? You know what I mean? And then I suppose when we're thinking about shared decision making, which is an emerging concept in all sorts, and we're looking at it particularly in mental health, it's like, well, at what point in my journey I might not want to, or I might not have the insight or the capability of having an active decision based upon how unwell I am at this stage. That does not mean that 2 weeks, 6 weeks, 2 months down the line that I might say, hang on a second, you said that we would try this medication. Okay, I've tried it. Now I've got this side effect. Can we have that conversation? Mm-hmm. And I want to know a little bit more about it. So, it's not to say that I want basic information, therefore I will always want basic information. It can be that, well, this particular case, I need to know more because I'm actually making this decision on the basis of somebody I care for. And so therefore I feel an added responsibility almost to do even more digging around this before I make that decision. That's kind of an example of.
Yeah, and immediately that makes me think of ChatGPT in the digital health space, because ChatGPT is very quickly becoming the new Google. Me and Sarah were talking about this recently, especially from a sustainability context. And people are going to ChatGPT and saying, these are my symptoms. Oh my God. But if you look at the output that it gives you, it's pages. Now, we're doing a small study within my group where we're comparing common questions for each of the So CF is a multidisciplinary condition. So we're asking each of the disciplines within the condition to bring in common questions, and we're running their expertise against ChatGPT. And it's interesting because all of them have said without fail is like, the information is not entirely bad. It is lacking context because it's fed a lot on, predominantly American generated content.
Yeah.
So maybe like types of tests or medications and stuff that might not work here, but the information is too much. And they would say themselves as healthcare professionals, we don't give that much because it's overwhelming and there's all this.
And it might not even be relevant.
No.
You've got a male in front of you and one of the contraindications is pregnancy. I'm sure ChatGPT will tell you that. But it might not be relevant to the person. And somebody else will be able to tailor. And we're all about tailoring information to the person in front of you. If you don't have liver disease, that isn't a problem for you. If you don't, you know what I mean? There are certain things. And so you don't need to go A to Z and list off every contraindication, every side effect, you need to say, who have I in front of me? What are their comorbidities? What are their other conditions? What are their other medications? And then tailor that information. And I think that's where you will never replace the person.
I know.
Yeah. And I think that's critical. I think for everything we've discussed in order to control it and perfect it and everything else, it does come back to the person at the end of the day. We're social beings. We're created for company. We're not meant to be on our own. We're not meant to live off devices. I mean, they have to be tools that we control, really. And I suppose the other kind of side of it then is communication across disciplines. You were saying CF is very multidisciplinary, but you also have like your medical devices, your biopharma companies.
Correct.
So with this growth and interest in better telehealth and digital literacy, where does it start? Like, does it start with the big industries communicating their products to each other and doing research? Does it start at the research level? Where does this collaboration and communication to build and improve digital literacy
For
kind of
me,
come
it's
from?
everywhere, but I like to start from the people who are using it.
Mm.
So like for me, it's always like if the staff are not confident with it, and the staff are the ones, like, I'm just going to use telehealth. There's loads of digital health solutions, but we'll just go with telehealth because obviously I have an invested interest. But like if the staff on the ground are not confident and they've already got a lot of skepticism and they're buying out, it's not going to be used anymore.
Yeah.
Great.
So they need to now have the skills. And likewise, I always think of digital health as it's so positive and the great impacts can have, but we have to be real about this as well, that there is an aspect of burden because it is additional to whatever you would have done beforehand. And with additional burden, it requires energy. So you have to keep that individual motivated. There's a honeymoon period with all these things and they fall off. So if your staff aren't skilled and they don't believe in it, then they can't motivate and give the energy back to the patient or the service user. And ultimately it's going to fail. So that is something we always have to know. And for anyone working from an industry perspective, then like if you were working in med tech or maybe you were developing a fantastic software solution, I would always say you have to consider it and you have to account for it. So like you need to be, like I've sat in on a few meetings now where we're looking at trying to implement some sort of digital health solution for something. And often the questions are like, but what if this happens? What if this happens? Because it's a fear. So, and usually that is quite solved by, we will come in and give you X amount of training. You'll all be fully confident in how to use it. And we'll always be there to offer support. And often that's usually enough to get rid of that initial phobia.
And I wonder, Tamara, is there an interoperability issue as well? Like, I mean, what I definitely see, like we would encourage in pharmacy and the Vice Dean for Interprofessional Learning, Aoife Fleming, would like bring healthcare professionals, social care professionals together. So they learn from, with and about each other to help the multidisciplinary team to function as a kind of a unit, if you will, focused on the patient. But what I would hate to see is like, well, down in the pharmacy, we use this piece of software, which doesn't talk to your piece of software.
Yeah. Interoperability is a huge issue. We kind of describe them as like siloed systems. And the more siloed the system is, we have data redundancy, and then you have duplication of data, and then that leads into our sustainability piece there.
And also fatigue. I have to put in the same data again. Are you kidding me?
Yeah.
And then your solution tends to come back to paper. So it's like, if I have data in that system and I need to bring it in on a report, I'll just write it down.
Maybe a post-it. Would a post-it work?
A post-it on the keyboard.
I think one of the things that really has to change, I think when we talk about a multidisciplinary team at the moment, we're not talking about software engineers or computer scientists as part of that team. And I think also a role for kind of organizational psychologists in understanding that kind of landscape of practice and the infrastructure that needs to connect. And I think then on the other side, when you look at software engineering as a discipline, or even software engineering, computer science in industry, that often there might be one token human computer interaction person who does people, as a colleague recently described it. So I think increasingly as our world evolves, and this is happening so rapidly, that we need to move out of our disciplinary silos, I guess. And we need to collaborate much, much more. And that's really hard. Things like we've talked about, kind of common language between, people working in health settings and a patient who's experiencing that lived reality. But I think even across the disciplines, having a language to talk about these things, we're still working that out. I just wanted to mention one book, which I think is really important in terms of, Laura, your point about thinking of health literacy as both, bottom up and top down, so the organizational element. But there's a computer scientist called Professor Harold Thimbleby, which I know Tamara and I have talked about, but he has a book called Fix IT. And he's almost like an investigative journalist in his work, but he has indicated that problems with technology actually account for a lot of problems in healthcare systems. He's looked at mortality, for example. So cancer, I think, is one of the biggest killers, but human error is the second biggest. And a lot of that is actually linked to computational problems. So he gives an example, for example, that might be of interest, Laura, to you from pharmacy. So drug dispenser machines in hospitals, they are not standardized across the world. So a nurse who needed to give a life-saving drug to someone pressed in the wrong code, and because of the security features, she pressed it so many times because that was the code for the medicine in the previous hospital she worked in. She got locked out of that system, and the system wasn't efficient enough for her to access someone to, get the right medication. That patient died. And there are so many examples of this that Harold Thimbleby has uncovered. I don't want to frighten people about this because it's definitely something that people are aware of and are working on. But I think Harold's work indicates the importance of someone from a computing background, just like you, Tamara, being embedded in a hospital background and seeing and understanding and observing these things. So as technology is designed and developed and becomes appropriated in life, we lag behind in terms of our standards and regulations. And we're really in that space now with generative AI, but arguably with a lot of other technologies that are used in healthcare settings. And one of the things I'm interested in is responsibility. So unfortunately, liability culture has also negatively impacted the kind of research space around these errors. So I think we want to move to a context that when a technical or technological digital error happens in an operational environment, that we want to really investigate that. We want to go, well, why did that happen? How could we do it different? But unfortunately, because of liability culture, that often doesn't happen, because even, if any of you are ever in an ICU, which hopefully none of us will be in the near future, but some of the machines on it, Harold Thimbleby talks about this, will have, if you die using this, like it's on you, not us, but for very crudely saying what they say. So it's that kind of defense. I'm very much coming for the United States, that kind of defensive liability culture, risk-averse culture. And I think somehow we need to find a way out of that so that we can really actually interrogate when problems happen, learn from them and do better. And I think interoperability, as you mentioned, is actually really the key word, isn't it? It's where these standards, these infrastructures of practice, how across disciplines we can kind of support that to work in context in the best way possible.
Yeah, and I suppose another key word to add there would be transparency, because if there is a lack of transparency, if things are covered up out of embarrassment, the thing isn't after working the way it should have, you're not going to improve. If the knowledge isn't shared,
and
you're
that
not going
comes
to learn from the mistakes.
That comes from big tech. So it's some of the tech companies that are involved in this. So and then also a doctor or a nurse is not a computer scientist. They don't know the computation. There's also examples of people being given, the wrong dose of chemo, for example, because of an automation. But actually the instruction that a nurse might have given was an appropriate instruction, but the way the machine was computationally designed, it needed a different prompt.
Semantic or syntax.
Exactly.
Yeah.
So we know that these mistakes happen, but I think we need to get into an environment where we interrogate them and learn from them.
I think with digital confidence that would happen, because, I think about the nurse situation where she put in the code wrong or dispensed it wrong, to stand proudly and say, I did the correct thing, or to be able to say that is the correct code, it's wrong here. That's not my fault. This is a standardization problem. But from my observation, it's very uncommon to have somebody blame the technology and not themselves.
Well, even in the UK, the legislation says that there is legislation. Yes. So Harold Thimbleby is a professor of computer science. So it's this idea that technology is neutral, which of course those of us that work in this space would argue against that. But actually that's enshrined in law in the UK. And as a result, in some of these medical cases, you have people like Professor Harold Thimbleby as a computer science, as expert witnesses supporting nurses, actually. The law needs to change, and we know that.
I think after that Postmaster scandal,
Absolutely.
I mean,
Yeah.
all the computers were wrong.
Uh, exactly. And
Yeah.
look, there are so many cases of that. And I'm not a legal scholar, so I don't know what the law says right now, but I heard Harold speak in Belfast, I think it was 3 years ago. And at that point, the law hadn't changed, and that was post that situation. But he was very active with other computer scientists in arguing the point that this needs to change, and it's a legacy thing. Yeah.
It's just bizarre that it would say that. So my brother is a senior AI expert, and I recently gave an AI machine learning talk, and I was chatting to him a lot about where it could be applied in different areas in CF. And we were talking about large language models, so like ChatGPT. And he said to me, have you ever asked ChatGPT to count how many R's are in strawberry? I said, no. And he was trying to explain to me how ChatGPT works on tokens and, breaking down the question to whatever. It can't count them. It probably has changed since, but it can only count 2. So you have to go, no, there's actually 3 there. And he'll say, oh, yes, thank you, as it does very politely.
It does very politely. Doesn't
Very
it?
politely. Unless you're not polite back, then it gets a bit off with you.
Okay, good to know.
Yeah.
Smiley emoji. Yeah. Do you know, I'd say we could just stay talking about this
All
for the
day,
day.
all
This
day.
is so
I know.
interesting, and we didn't even touch on Skynet or any updation there. But I suppose I'm going to finish up by asking you a very controversial question. If each of you could take it briefly, and I don't mind who goes first. Given everything we've talked about, the benefits, the advantages, potential disadvantages, tech failures, data centers and all that, advantages like communication for our patients that might be otherwise isolated, and I suppose better understanding for your own healthcare as well. Can we actually do without digital health literacy? If you compare healthcare from the past, and I would have heard from the matrons of the past, bring back matrons on the nursing ward and all of that. Are we better off with the older model or the newer model of digital health, telehealth?
So I will say, I don't think it's an either or.
Mm-hmm.
I think that it's like the wave. You're not going to push it back. Digital literacy, digital health literacy, it's here. And I think it's up to us to develop the rules around engagement with it. And I think core to that is having your trusted healthcare professional to aid, to accompany you, to guide you, and to seek healthcare professionals' trusted information, to not go into some echo chamber on Google or whatever to try and answer your health-related questions. There's too much dis and misinformation out there on every front. So I would say, yes, we need health literacy, we need digital health, but please go, I suppose, quietly towards that aim and go hand in hand with a trusted healthcare professional to help you.
Yeah, very good and very diplomatic. Yeah, very good.
Just to repeat the questions, then, can we do without it, or should we go back to an older model? Abstractly, my knee jerk was to say no, even though you could look at this objectively and say it always did work previously. But I do think the nature of health conditions, living longer, it's getting more complicated. I also think, population density is getting higher. The amount of healthcare professionals, it's getting lower. So there's a lot of things we're trying to combat, and this is a possible solution. And I think turning back to old systems, which I'm not discounting the individuals, like you mentioned, matrons. I say bring back the matrons on the ward. I don't mind that. But like paper-based systems, I don't know if it work. With the health literacy part of it, I can't say it better than Laura. She just nailed it. But it's absolutely, you need to move with it. And I would love to see it in a more co-creative and accessible space. We start talking more about the well-being of it, and wherever you are on that digital health literacy continuum, you start where you're most comfortable and you go to where you can be comfortable. But like, again, we're in this world of mis and disinformation. As the World Health Organization says, we're in an infodemic.
Yes.
So we can't stop the tidal wave, but what we can do is try and make people more aware of it and know where to go should they get a bit lost, back to their healthcare professionals.
And Sarah?
I would agree with what Laura and Tamara have said. And and really what Laura said in terms of it's not either or for me. So if we go back to that idea of 3 billion people in the world don't use the internet. So when we talk about digital health literacy, sometimes we're leaving them behind because some of them won't have basic literacy. So I think literacy in general, and then targeting that literacy to the context. So in contexts where the digital world is now ubiquitous, like in our world, then people absolutely have to have health literacy and be supported to have it. It's not on them. But I think your point about the old, what I was hearing was people, and people are so important. And I'd love to see as digital technologies are evolved, that they're supporting us to have more time with people and to cut out maybe some of the mundane or things that can be automated to enable more people to be freed up for care, for the relational aspects of medicine and health, which I think are really central. So I don't think it's either or. And I think, to echo what Tamara said, I think co-creation and considering where we're all at and where we need to go. So, technology is advancing rapidly and we're all lagging behind with that. Sometimes I'd like to put a halt on that bit, but bringing people with us and having more, I guess, getting rid of silos in general. So be them disciplinary, and then the gaps between the people who are affected by health conditions and the technologies that are supposedly there to support them. Yeah.
Yeah, I think my own tuppence worth, I think the success or not of the development of digital health literacy will be down to collaboration and communication. In short, and if it can be done simply on some kind of a standardized platform that is quick and easy access, usable across lots of devices and stuff like that, and that the skills are simple, relatively simple to pick up and share and stuff. I think that's where you'll see success. But I think we'll have to leave it for another day. I think there could be a part 2 that was really,
just
really
one part
interesting.
there, just in case there's anyone from the HSE listening. There's actually digital literacy training on HSE land that you can go look at. And if there's anyone from the general public, if you link in with your local libraries, there's a lot going on there. So if you're interested and you do want to actually start exploring that, local libraries have a lot of different things you can start with immediately.
And maybe just to add that UCC Library also have an increasing number of digital literacy skills that they can impart through various different courses that are available to students.
To be fair, it's all libraries actually. Public libraries, health libraries, and the university libraries are offering
libraries
things.
are where it's at.
That's right. I was completely unaware of that. So that's fantastic.
And as staff, I think there are some trainings that we can do as well in the library.
Fantastic. So it's something that might be embedded in undergraduate medicine and science courses, we don't know, perhaps, but in the libraries at the moment. So really good. It was extremely informative and really interesting. And I'm very grateful that you made the effort to come in and have a chat today.
Thanks so much for having us.
Thanks. Pleasure was all mine. Okay. Thank you. Thanks very much.